Hi, I'm Dr. Bawarshi. I'm a psychiatrist in Tampa, Florida area at Florida TMS Clinic. I'm going to be making some videos answering most commonly asked questions related to treatment-resistant depression and TMS. So today's question is, I am about to start TMS and I am on an antidepressant. What should I do? Should I continue my antidepressant or should I stop it? All right. So the short answer is continue taking your antidepressant until you're done with TMS, and then you can decide with your psychiatrist what you want to do next. All right. But obviously things are more complicated than that, so we're going to dive deeper into this and see how we came to this conclusion. So let's remember a little bit about the history of TMS. So TMS was FDA approved in 2008, and the pivotal trial was published in 2007. Obviously there are years of work before that, to kind of show the efficacy of it. So when you need to prove the efficacy of a treatment, you want to make sure that this is a pure effectiveness of that treatment, not related to other factors. So for this reason, the pivotal trials that proved the efficacy of TMS went through a washout period for patients before they started TMS, right? So patients will be taken off of their antidepressant gradually, and then they will be not taking any antidepressant for 1 to 2 weeks before they start their treatment in the pivotal trial. So let's look at that. So this is the pivotal trial that was published in 2007, and we can see in the selection of patients in here. Here we go. All patients were free of antidepressants or other psychotropic medications directed to treating depression. Patients were allowed only limited use of either hypnotic or anxiolytics for treatment emergent insomnia or anxiety, and up to 14 daily doses of lorazepam, 2 milligrams a day equivalent, only were permitted. Okay, so what they're trying to say is that we know that hypnotics could actually decrease the chances of a brain responding to stimulation. So for this reason, when patients are having problem with insomnia or anxiety during TMS, we did not give them more than 2 milligrams of lorazepam. And that's important because when I answer the part about benzodiazepines, that will come up again. All right, so let's look at the second pivotal trial, or the NIH trial that was published in 2010. Okay, so that clinical trial also had a couple of hundreds of patients at that time. So let's look at the patient selections in there. Okay, all right, so here we go. All randomized patients were free of antidepressants, antipsychotics, and anticonvulsant medications for 2 weeks before baseline assessment, 5 weeks for fluoxetine. So fluoxetine, which is Prozac, has longer half-life, so 2 weeks is not enough for the patient to be off of the antidepressants. So for fluoxetine particularly, they went with 5 weeks. Okay, all right, similar idea. They were allowed only limited amount of benzodiazepines during that time. Again, because benzodiazepines are hypnotic to the brain, and you're trying to stimulate the brain with TMS, so you don't want to decrease the chances of a stimulation happening. Okay. Then you have the Deep TMS clinical trial that was published in 2015. Similar thing happened there, for the selection of patients. So study design included 3 phases. The first phase was a washout phase for 1 to 2 weeks, in which patients were tapered off of all antidepressants, mood stabilizers, and antipsychotics. Okay, so I hope that you got the point. At that period of time, we were trying to prove the efficacy of TMS, and for this reason, we wanted patients to be off of their antidepressants. Now, if we do that in real clinical life, what is going to happen? Well, some patients might have serotonin discontinuation symptoms, and that would mean that their depression will get worse. And if their depression would get worse, then their chances of responding to TMS might be less. Another factor that plays a role in here is that there had been some trials here and there seeing if we do an antidepressant and TMS at the same time, would we have better chances than just TMS on its own? And the answer is yes. That is reported. Even the pivotal trial, when they were going through the maintenance phase, they put patients on an antidepressant, and that group with an antidepressant had better outcome than the one without an antidepressant. Okay. So knowing this, now when you're designing future clinical trials, you don't need that part anymore, okay? Because as long as you were adjusting the control versus sham, or the two arms of the trial, you should be fine. So let's take an example in here. This is the trial in 3D trial, the one that proved the efficacy of theta pulse stimulation. All right, one of the best trials in design. And then we look here at the selection of patients, and they had received a stable antidepressant regimen for the last 4 weeks before treatment, which was continued during treatment. So notice the theme now. We're continuing the antidepressant. All right. Let's look at SANT-TRD. Okay, so SANT is the Accelerated TMS Clinical Trial. This is the open-label trial one. And in that one, similar thing happened in there, that the patient participants were required to maintain their antidepressant regimen during the time. Okay, let's look at the most recent published one, which is SNT, which is similar to SANT, but it's randomized control trial. Participants were required to maintain a stable antidepressant medication regimen or remain on their medication or remain medications free for 4 weeks before the treatment. So patients who are not on an antidepressant, they just needed to continue to be free. We don't need to add another factor during the clinical trial that could confuse the outcome. All right, so hopefully this delivers the answer, is that you continue the medications, during TMS, and then after that you decide on what you want to do after this, after response or no response. Okay, now how about other medications? Let's be a little bit more specific. How about Wellbutrin, which is bupropion? So bupropion carries a risk of seizure for patients who are on more than 450 milligrams of the medication. And then you're doing TMS, and TMS does carry a risk of seizure. Now, to clarify, the risk of seizure with TMS is extremely rare to happen. I'm talking about 1 in 30,000 treatments. Actually, in real life data collected for a few years, the actual rate of seizure is 1 in 89,000 treatments. Okay, so it's even less than what we expected originally. I've been doing TMS for the last 3 years. I've done over 20,000 treatments. I've never had any seizure happening. I'm careful about who I'm selecting for the treatment, and we have really high standard of care and what have you. But regardless, you could tell that the risk of seizure is extremely rare. But when you have another reason for risk of seizure, you want to adjust that risk a little bit. So sometimes I decrease Wellbutrin from 450 milligrams to 300 milligrams before starting somebody on TMS. All right. Okay, well, let's expand the question a little bit. How about benzodiazepines, right? What if a patient is on Ativan, which is lorazepam, or Klonopin, which is clonazepam, or Xanax, which is alprazolam, or Valium, which is diazepam? So what are we going to do then? Well, then we know that those benzodiazepines are hypnotic to the brain, and that could work against TMS. And there is an evidence of that. There had been a clinical trial that I don't remember what year it was published, 2019. In that clinical trial, they were looking at different medications and what happens, for patients' response in these scenarios. And you can see in here that patients who were taking a benzodiazepine during their TMS had less response rate than those who were not taking benzodiazepine. And they had less remission rate than those who were not taking a benzodiazepine. I think particularly in this trial, they were considering use of benzodiazepine as more than 2 milligrams equivalent of Ativan. If it's less than 2 milligrams equivalent of Ativan, then you have similar response and remission rate. Okay, so the answer to a patient who's taken more than 4 milligrams of Klonopin is like, well, let's try to taper down Klonopin first and then go through TMS. Now, would it be completely wrong to do TMS for somebody who's taken higher dose of benzodiazepine and they're not able to tolerate a decrease of their medication? No, it's not completely wrong, but we have to inform the patient that now their chances of responding to TMS is less than if they were off or if they were on a lower dose of a benzodiazepine. Okay? All right. Let's make the question a little bit more complicated. What if somebody has a comorbid ADD or ADHD, right, and they're on a stimulant, right? How does that affect TMS? Well, there is some good news in there. So first of all, we need to know that higher dose of stimulant also increase the risk of seizure. So patients need to know about that part. But again, because seizure risk is negligible with TMS, it's also negligible with the psychostimulant. So it's a risk versus benefits that is tolerable, what I would say. But the good news is that if you're taking a psychostimulant, the chances of responding to TMS is actually higher, and that's shown here on the graph, right? So patients who are taking a psychostimulant has higher response rate and higher remission rate compared to the ones who are not. Okay. And it makes sense because you're trying to use magnetic stimulation to stimulate the brain out of depression. And if somebody was taking a chemical stimulant already, then that could actually increase the chances of response. So I would not take a patient who's on a psychostimulant off of their psychostimulants before doing TMS. And also sometimes in some rare anhedonic depression cases, I could add a small dose of a stimulant in the middle of the treatment if the patient is kind of lagging in their response and they're delayed, they're not showing response yet. Okay, so hopefully this answers the question. I have to read some disclaimer to you. All right, so although I am a psychiatrist, this is not a professional advice. As I am not familiar with the specifics of your unique situation, please contact a psychiatrist in your area with more questions. This disclaimer is added to my answers on social media after consulting with the American Psychiatric Association. All right, okay. If you have any questions, you can submit them, and I'll try to give a general answer similar to this one. Thank you. Bye.